You will find the information for coronary artery disease in your Lewis book, 731 to 735. Coronary artery disease continues to be or have or leading cause of death. It continues to account for the majority of deaths, especially when it comes to cardiovascular disease. Patients with CAD can sometimes be asymptomatic. They can develop chronic stable angina, which we call chest pain, or unstable angina, and myocardial infarction, which we all know that MI is obviously a much more serious manifestation of CAD. And you'll many times will hear it called coronary artery syndrome, or ACS. It's estimated it does take quite a few people every year. At least 1.1 million Americans will have an MI each year, and about 1/4 of these will actually end up dying. Some of them will die before they even get to the hospital, or some of them will die in the ED. So, luckily, with advances today, some of these MIs have decreased. But although we have these great advances, it still continues to remain the leading cause of death for all vascular disease and death in general. And if you look at the graph, you can see that initially men tend to have higher risk factors, but then it increases or it equalizes with females once a female reaches menopause. This is just another graph that's showing you some of the differences between the males and the females, and the different years and deaths in the thousands. Same thing with this graph. Just showing you the leading causes of death, with the blue being coronary artery disease. Okay, so this disease process all begins because of atherosclerosis. And if we break it down, coronary artery disease is actually considered a type of a blood vessel disorder, but it's in the category of atherosclerosis. And atherosclerosis, all it is a fatty mush that will develop in our arteries over time, and it initially begins with a soft deposit, and then it will just harden over time and with age, and it'll just become harder. So that's why we call it the hardening of the arteries. This condition does occur in our arteries in the body, and for some reason this fatty deposits tend to have a liking to our coronary arteries. And this is when all the trouble begins, because we have these fat deposits that continue to build and build, and it continues to increase with age. Atherosclerosis is a major cause of CAD, and if you can look at this diagram, it's showing you the different types of occlusion and what they mean. And when the doctor goes in and does an angiogram, where he can see how much of atherosclerosis of development, or this plaque, is inside the different coronary arteries. And over time, I did say that it does continue to get worse, and if there is some endothelial injury and inflammation, these also play a role in the development of this. And these are some of the stages of the atherosclerosis. We all initially begin at stage A. When we're young, we're born with brand new plumbing, but over time the plumbing gets more and more plaque, and all of this even begins as we're children, and slowly we start developing this plaque, and we can even see some pretty fatty streaks, and pretty nice size, usually by the age of 15. And going back to the A, that is in the inner lining. It's non-reactive to platelets or leukocytes, and you can see it looks pretty clear. And then if you look at B, we start developing some fatty streaks, and this is would be considered like an early lesion of atherosclerosis, and is characterized by lipid-filled smooth muscle cells, and these are the ones that you'll start seeing by the age of 15. By the time you get to C, there's more of a fibrous plaque, and it's the beginning of the progressive changes in the endothelial of the artery wall. These can start appearing usually by the age of 30, and it starts increasing with age. And once this endothelial injury has taken place, you have lipoproteins. These are carry proteins within the bloodstream. They transport cholesterol and other lipids into the arterial intima. Collagen then develops, covers that fatty streak, and forms the fibrous plaque. These plaques can form some portions in the artery in a singular fashion. And then over time, then you end up getting into D, which is a complicated lesion. With this one is the most dangerous because the fibrous plaque will grow and will create some inflammation, instability, and once integrity of the artery is compromised, platelets tend to go because it senses injury, and it will create a thrombus, which is our body's natural response to injury and inflammation. And the thrombus adheres to the wall, and unfortunately it causes more narrowing, and at one point we'll get to like the picture that we saw where it's almost 100% occlusion. This one can show you about 90% blockage. And as we can look at the diagram, our heart on our left side has major supply of oxygen into the heart. So when we have injury on one of those sides, that's when people really start feeling the symptoms of the shortness of breath. They're unable to breathe. They have the ischemia and the chest pain. Okay, with C-creatinine protein, what this is a protein that is produced in the liver, and it is a non-specific marker of inflammation. The level of CRP rises when people have a systemic inflammation. These elevations are usually associated with unstable plaques and any kind of oxidation of the LDL. And unfortunately, this continues to contribute to atherosclerosis. Now, as far as collateral circulation is concerned, the beauty with collateral circulation is that our body will create these different avenues to make sure that there is blood flow into our heart because the artery is blocked, and it needs to find a way where it can go and continue to provide oxygenated blood into our heart. There's two factors that contribute to the growth to this collateral circulation. One of them is inherited. It's an inherited predisposition to develop new blood vessels, which scientific name of it is called angiogenesis. The other one is if someone has a continuous presence of chronic ischemia. So when the plaque completely occludes or begins to occlude the normal flow of blood, and it results in some form of ischemia, then collateral circulation will develop. And when occlusion of the artery occurs slowly over time, there's a greater chance that you'll have much better collateral circulation. And these myocardial cells will continue to receive this amount of blood and oxygen at undisturbed flow. It's not as good as, of course, our coronary arteries, but it is an avenue to still get what we need. But if someone develops CAD very rapidly, it will not give the body time to develop this collateral circulation. And this diagram is just showing you what I was talking about with collateral circulation. And now, as far as risk factors, there are risk factors that people can do something about, and then we have risk factors that they cannot do anything about. Some of the risk factors are age, and with age, as I mentioned earlier, this plaque development continues to develop with age, and it gets bigger and bigger. And the other one is gender. I talked about men are generally at greater risk of coronary artery disease, but the risk of women increases after menopause. Family history. If someone has a family history of heart disease, they tend to have a higher risk of coronary artery disease, especially if it was a very close relative and if this happened at an early age. So, let's say, for example, a patient has a father who developed heart disease before the age of 55, or a brother or sister that developed this before the age of 65. It puts them at a much higher risk than the general population. And genetic predisposition, of course, is and nothing that people can do about their genes. So let's go now to modifiable risk factors. Modifiable risk factors are those things that we can change or we can do something about. So if someone tends to have a bad diet or they have elevated serum lipids, they can increase their activity or make sure they inform their physician so they can be placed on a statin. Uh, any kind of elevated blood pressure. I'm sorry, I'm talking about. Oh yeah, blood modifiable risk factors. Blood pressure. Patient can take medication to help control their blood pressure. If they smoke, we can tell them to perhaps join a smoking cessation program. And the thing with smoking is because nicotine will constrict your blood vessels and carbon monoxide will damage that inner lining in the coronary arteries. So what it happens is that these coronary arteries now, because of the damage and the constriction, are more susceptible to atherosclerosis. And especially if a woman smokes, it puts her at 6 times more of a risk greater than a woman who's never smoked. And for men who smoke, it almost quadruples their chances of getting coronary artery disease compared to non-smokers. This diagram is just showing you the different diets and the different things, causes, and risks. I mentioned some of them. Now, as far as obesity, what happens with obesity? There's just excess weight, and this excess weight just worsens the other risk factors. High stress, unrelieved stress in our bodies will cause damage to our arteries. Another one I talked about blood pressure. If the blood pressure remains uncontrolled, it results also in hardening and thickening of the arteries, which narrows the channel through which blood can flow. I already talked about some of these modifiable risk factors, and hypertension happens to be the second major risk. Any systolic blood pressure greater than 140 over 90, or if someone that is diabetic, greater than 130 over 80, or if they have chronic kidney disease. It does increase their death, and the stress of this elevated blood pressure continues to increase the atherosclerosis development. And I talked about smoking. Smoking is actually, or tobacco use, it's a third major risk factor in CAD, so it's quite high up there. And I did say it's CAD, the risk of developing CAD is 2 to 6 times higher for those that smoke when you compare them to those that do not smoke. Tobacco smoking also decreases estrogen levels, which places premenopausal women at risk for CAD. And then another thing that nicotine in tobacco smoke causes catecholamine release, which that's your epi and your neurepi. And these increase your heart rate and cause peripheral vasoconstriction. Therefore, that equals to increased blood pressure as well. And this will increase the workload of the heart. More modifiable risk factors. Physical inactivity, of course, if someone's leading a sedentary lifestyle, lack of exercise has been associated with coronary artery disease, and once again, the risk factors as well. I talked about obesity. Now, as far as diabetes, with diabetes, it's associated because when you think about conditions such as obesity and high blood pressure, these all seem to share the same risk. And the incidence with diabetes with CAD is about 2 to 4 times greater than those that do not have diabetes. And that goes for even people that control their blood glucose compared to the general population. Metabolic syndrome. Now, with that one, it just refers to a cluster of risk factors of CAD, uh, those whose underlying pathophysiology may be related to insulin resistance. More modifiable risk factors. We have psychological states, and with psychological states, we're talking about things such as those people that are, they say, have a type A personality. They're perfectionism, hardworking, driving personality. But what happens with them is that these type A personalities often will suppress anger, hostility, and they don't give themselves time to relax. They're overachievers, which may sound like a good thing, but when you don't give your body a time to de-stress, then that stress continues. Or if, let's say, someone has this type of personality, but at the same time they don't put any or do any changes with their diet or add exercise to their daily routines. Now, with homocysteine, all that is just high blood levels of this homocysteine. It's like it's produced by the breakdown of essential amino acids, and that's is found in dietary protein. These high homocysteine levels will contribute to atherosclerosis. Substance abuse, drugs such as cocaine, methamphetamine. What happens with these is that they will create coronary spasms, and which this will result in myocardial ischemia and chest pain. And at times, MI can occur because of the continual spasms. And these patients will have very high heart rates, tachycardia, high blood pressure, angina, anxiety. Now, one of the biggest roles we play when we have these type of patients is prevention and early treatment. We have to identify people pretty early when they're high risk, so that is usually found when we do history and physicals. We want to find out about their family history as well. We want to find out any kind of what is their environmental situation. Are they that type A personality, psychosocial history, any kind of values or beliefs that they may have in regards to illness. And of course, physical fitness, as we know, we've been talking about it. 30 minutes most days. Should try to do a little bit of weight training 2 times a week. And when it comes to our elderly population, we just got to make sure that they're cleared by their physician before they exercise. But just walking 30 minutes a week, 3 times a week, makes a big difference with CAD development. We want to manage people that have high risk factors. We want to recommend any kind of preventative measures. Risk factors, as we talked in the beginning of the lecture: age, gender, ethnicity. People that have these high risk, we can still help them by reducing the risk of CAD by controlling things that are modifiable. And as we talked about too, that non-modifiable risk factors, unfortunately, we can't do anything about that, but we can do something with the modifiable risk factors. Now, as far as nutrition is concerned, Actually, this one's just talking about physical fitness again. And I did mention a little bit about this in an earlier slide that we want people to do about 30 minutes a day plus a little bit of weight training 2 times a week. So that's really all you have to know is encouraging physical activity and, of course, getting the clearance from their physician. Now, nutritional therapy. We want to make sure that these patients are decreasing their saturated fats and cholesterol, but at the same time, we want them to increase their complex carbohydrates and fiber. Fiber is very good. And a large intake of red meats and egg yolks and whole milk, we would like a reduction in that. These are sources of saturated fat and cholesterol. So either we should have our patients have them reduced or eliminated if possible. And if the serum triglyceride level is high, we recommend, and the guidelines recommend, eliminating alcohol and simple sugars from their diets. Omega-3 fatty acids, they help reduce the risk of CAD when people eat this regularly. So for individuals with CAD, the AHA recommends eating fish at least twice a week because fish, especially fish like salmon or tuna, contain 2 types of omega-3 fatty acids. Just another diagram showing you the different kind of diets and the different types of categories that they fall into. Now, drugs, such as lipid-lowering drugs or statins. Because initially, what a physician will always order is the natural things, such as trying to change a diet, trying to add exercise. Now, if this is unaffected or not enough, then a statin is thrown into this treatment plan. Usually they'll reserve this kind of treatment for anybody who has a cholesterol level greater than 200, because a cholesterol level greater than 200 puts people at a really high risk for CAD and should be treated. And some of these treatments will begin with starting to cut back on calories, especially if someone is overweight, because we know that obesity also plays a role in the development of CAD. And like I said, some of the statins will go ahead. These are the different categories. We have the statins and the niacin. And the ones that are widely used are the statins. They'll be the ones that are usually you'll be administering these to your patients. And sometimes some of the serious adverse effects of these drugs do include liver damage. Sometimes they'll get myopathies that unfortunately will progress to rhabdomyolysis. That's why some patients will hesitate to take these drugs, because of the different side effects these drugs give. Then other statins such as niacin, these are like a water-soluble B vitamin, and it's very effective in lowering LDL. Remember, LDL is a bad cholesterol. HDL makes your body happy, so it's good. HDLs are a good type of good cholesterol. And niacins will also help with increasing HDLs. And other than that, it's pretty much just know that there are different categories, but nothing's too specific. Cethia, I did talk about Cethia. This one inhibits the absorption of dietary and biliary cholesterol, and sometimes it will be used as an adjunct to dietary changes. Lipid lowering drug therapy, we have Lopid. We have, unfortunately, with these, it gives patients GI effects. Like they'll get nauseous, heartburn, abdominal pain, bile acid sequestrants. What these do, they just increase the conversion of cholesterol to bile acids and decrease hepatic cholesterol. So the primary effect is in a decrease in total cholesterol level. And the administration of these drugs will also give you, like I said, heartburn, nausea, abdominal pain, constipation. And Zetia is a category of drugs that decrease cholesterol absorption. Then we have collaborative and nursing management. We have, unless it's contraindicated, if someone has a GI bleed, then of course we're not going to start them on aspirin or Plavix. A baby aspirin, if you ever heard of the term baby aspirin, all that is 81 milligrams. And this is what's recommended for most people at risk for CAD. So this is not someone that has CAD, just someone who's at risk for this. Some of the recommendations for men over 45 and high-risk women is taking a low-dose aspirin. If a high-risk woman is intolerant to aspirin, then Plavix can always be a substitute. And aspirin therapy needs to be considered if blood pressure is controlled, and the benefit for MI prevention outweighs the risk of GI bleed or hemorrhagic stroke, which will be sometimes some of the reasons why some people don't want to take aspirin or Plavix. As far as your general population, we know that over time this was going to increase. So your geriatric population will have much higher risk than any other population. And another thing with our older population that they have other comorbidities. They have other risk factors that they've been doing for a long time. So tobacco use or risk factors such as inactivity. Strategies to reduce CAD risk and to treat CAD are effective in this age group. Aggressive treatment of hypertension and hyperlipidemia will sometimes stabilize some of these plaques in the older adults, but they need to stop smoking. And if they do this, it actually this helps decrease the risk of CAD at any age. When this general population is going to have any kind of physical activity, they need to warm up, and they need to warm up for a longer period of time than, let's say, a young person that doesn't have any comorbidities. We got to make sure we educate our little elderlies about heat intolerance, because the older adult has a decreased ability to sweat effectively. They also have that if they have, like, let's say, diabetes and things like that, they have a less chance of feeling changes in temperature or feeling hot. The older adults should exercise a minimum of 30 minutes on most days of the week if possible, but we'll take 3 if that's all they can do. Our goal is to encourage the older patient to adopt healthy lifestyles, especially if they're at high risk for CAD. Even someone who's at risk for fatal cardiac events. Now, as far as with your elder patient, when these are two points to consider. When hospitalized and when symptoms such as chest pain are a result of CAD, keep in mind that this is not part of a normal aging process. So the first thing you're going to do is assess the older adult for readiness. Anytime we teach anything at all, we got to make sure that they're ready to learn, or else our teaching will be completely ineffective.